Can everybody hear? Okay. I'm going to start with two disclaimers. The first one is, we're starting late, so at the end of my presentation, it's not my fault. Second disclaimer is, looking at the audience and the presentation we've had so far, I'm not a theoretician, so I hope the presentation meets your expectations. And with that, I was asked to speak about the role of technology in driving process change within healthcare. And that's a topic near and dear to my heart, so this is probably a good thing for me to be doing. This is the outline of what I'm going to be talking about. I'm going to present a case. Then I'm going to talk about perhaps a philosophical discussion about what are the controls for healthcare quality and cost. And then branch to the true topic I'm discussing today. What is the role that technology can play in managing quality and cost? What electronic medical records have not been able to do, what a process-focused clinical architecture can do, and discuss technology as a driver. So first, I always like to start these presentations with a case. This is a case from a number of years ago. I've presented this case previously. It's a case of a young man named Louis Blackman. He was a 15-year-old boy who underwent elective chest wall surgery at Medical University of South Carolina. I don't know if you've ever been there. I've been to MUSC. It's a lovely place. I have colleagues there. We've met and visited the facility. It's a great place as an excellent academic health science center. Nevertheless, in care there, Louis bled to death post-operatively over the course of 30 hours. During this time, the nurses and the medical trainees, the residents, assessing him, overlooked worsening abdominal pain, distension, pallor, and severe tachycardia. For the last 2 hours of his life, he had no blood pressure that was measurable, while the staff looking after him went and got additional blood pressure cuffs to try to figure out why they couldn't get his blood pressure. Now, this is all public domain information. You can look it up yourself if you'd like. It's a very challenging case. Many people would say, well, that's just an exception. That's a really bad case. You just found a really bad example. That doesn't really happen. Well, those of us who work in healthcare know that that's not true. My service, our General Internal Medicine, we do M&M rounds every month. We have at least 2 cases to present every month. And they're not always perhaps as bad as Louis, but they're bad, right? And we meet, we talk. When you do those presentations, on the first slide, they put the first slide. I go, oh, almost immediately what's gone wrong. I'm old. I look at the case and go, oh, but I bet this is going here. And then a few slides later, we go, yep, there it is, yeah. Okay, so we do that, and what happens? What did they do? They cried, and they said they were sorry, and they said, we'll do better. But like the rest of us, they don't really do anything real. Nobody does. And I'm going to be a little harsh here, but my expectations of what people are supposed to do with these things are fairly high. We could take this, we discussed earlier, already we discussed presentation of evidence and management of evidence. It's a microset of this problem. If you can't apply evidence and change practice, that's a sign that you're having a problem delivering certain metrics, certain outcomes from healthcare. This is the extreme end of that, right? We use the same techniques to implement evidence-based medicine as we use to deal with morbidity and mortality events. We encourage people to be better. We have rounds. We discuss it. We do in-services. Those are the tools that we seem to think will deal with this stuff. And I can assure you, it will not. So I want you to ask yourselves, why is it that no healthcare system, none of them, are able to control care quality and cost? Why is that? It's very odd problem. And I'll show you how odd that is. So the primary control we use for healthcare quality is professionalism. Those M&M rounds I'm referring to as a tool of professionalism, right? We discuss, as we get together as a group, we discuss this stuff. That is our professional mechanism to control quality. That's what professionalism means, right? You get a bunch of professionals together and you talk about it and you make a plan. I respectfully suggest that really you're balancing a great deal of problems on a very slippery surface if you believe professionalism alone will do this. I'm not so heretical to suggest professionalism isn't important. It's extremely important. It's what's holding the healthcare system together right now. So I'm not suggesting it's bad. I'm suggesting it's not enough. Being professional is really important, but that's not enough to deliver true value in terms of quality and cost. And this is what professionalism really boils down to. We flagellate everybody when they do something wrong. Now we're not quite as severe as we used to be about it. You know, the shame, blame thing people talk about, that's basically what we do, right? That's what M&M rounds are, right? Somebody presents, everyone starts saying, now remember, we're not blaming anyone. Let's not do that, right? But then we go and do it, right? And hopefully, in most of the cases we get to do, the people we're really going to blame aren't in the room, right? It wasn't us, it was the surgeons, it was the emergency guys, it was an anesthetist, it was somebody other than us, right? So, you know, they're not in the room anyway. So you can hint at their fault, their blame. Not really a very effective mechanism. But that's basically what we're doing. So what are we left with? We're left with professionals. Here's our Harried Doctor with all the things this poor doctor's trying to keep in his head. Right? Always check allergies. I've got to calculate CHAD scores. And you saw some tools talk about that earlier, right, today. Right? All the things, and they're just running around this person's head. That's how we're trying to manage quality. Let's look at our nurse. What's our nurse doing? Here's our nurse, and here's what he's trying to remember, right? Okay, call bells. Which patients am I supposed to turn? Have I turned everybody I'm supposed to look after today? Am I on schedule for turning the patient? Right? Oh, I got to check about the medication. And we went to the drawer, it wasn't there. Oh, I forgot to go get that. Right? Follow-up appointments. We just finished talking about the piece of paper in the pocket, right? That's where it is. It's in their pockets, right? And I'm sure I'm forgetting something. Any ring a bell? All right. Let's switch to costs. How does healthcare control costs? Well, David Bates already showed this graph. How does healthcare control costs? The simple answer is it doesn't. Right? It doesn't manage costs. That's what this graph says. Everyone looks at graphs. When I went to undergrad, I was taught to read graphs. People don't seem to know how to read graphs. This graph is telling you that none of the Western democracies can control healthcare costs. Now, I want you to ask yourself a different question. Why? No industry in the world has curves that look like this. Nobody has curves that look like this. Doesn't it seem odd? The auto industry is not taking over our economy. It is not getting bigger and bigger and bigger and consuming more and more of our economy. Even the oil industry, I've got to be careful what I say here, isn't taking over the economy. But healthcare is. Doesn't that seem strange? Right? No other industry behaves like this. Right? So I'm going to make a distinction between real businesses and healthcare. Okay? Real businesses work like this. I basically want gas for my car. I get the gas, I pay the gas station. They got the gas from somebody who delivered it to them. They pay them. They got it from a refinery. They pay them. The refinery got it from the pipeline. They pay them. The pipeline got it from the oil well. They pay them. This system is automatically self-regulating, right, across all domains. Profit loss, quality cost, supply demand. It functions by itself. Right? This is Adam Smith's invisible hand he was always talking about, right? It doesn't need an overriding intelligence to make it work. The only thing you do need is you need laws and governments to keep everybody from lying to everybody. That you can't control because there's incentive for everybody in this process to lie to each other. So you got to have laws and lawsuits and SEC and stuff to keep this working. But it works by itself. Nobody has to do anything. Healthcare, on the other hand, functions a little differently. There's our patient over on the one side, and there's the providers, the doctor and the hospital. The patient's going to receive services. The patient is paying the government. The government is paying the doctor. They're paying the hospital. The hospital's buying supplies from the pharmaceutical industry, and they're paying them. Does that look like capitalism? It isn't. Right? You can pretend it is, but it ain't. Right? You could replace the government with insurers in the United States. The drawing looks the same. Right? The Americans themselves, no offense to any Americans in the audience, don't understand. It is not a business. If it was, the cost curves would not look like that. Quality would not be something you have to argue about inside hospitals. Product quality, most businesses, all businesses that want to survive, manage automatically. We don't. Not automatically. We try to deal with it, but it isn't automatic because it's not built into the model. So this system doesn't self-regulate across any domain. It is incapable of doing that. Again, that's what that curve says. That's what these continuing incidents tell us. So, if neither of the existing control mechanisms are working, we need to consider the role of technology in healthcare. So where are we today? Most of us as healthcare providers, and those of us like myself who use technology in healthcare. Our vision of technology in healthcare kind of looks like this. We basically ask of technology, can you tell us a answer to life, healthcare, and everything? And the answer is an electronic medical record. And I go, okay, and how is that going to deal with the problem I just finished talking about? How exactly? Well, it's going to do everything. Really? Okay. And I'm a huge advocate of electronic medical records, but this is the level of dialogue you hear. And even in the popular press, right? Oh, we've got to have electronic medical records. I see these articles in the newspaper, and I go, I never see an article in the newspaper that actually explains why. It's just kind of magic's going to happen, all right? I go, really? In general, magic doesn't happen in this world. Here's a quote from the Globe and Mail back in November. They were talking about e-health in Ontario and so on, and often, okay, a little Ontario-centric, I apologize. But anyway, convinced that electronic connections between patients and clinicians will forge better, cheaper health care. The provincial and federal governments have lavished cash on health information technology in pursuit of the sort of cost efficiencies and quality improvements that were captured long ago by banking, travel, telecommunications, etc. Real businesses got these benefits, but somehow we didn't. Why not? Well, I've already kind of covered my opinion about that, as to why that is. So if you're going to get benefits from technology in healthcare, it's going to take more than just motherhood statements saying, let's get some technology in here and see if it works. That's not going to do it for us. So the true benefits of electronic medical records have yet to be realized because we have focused on electronic versions of existing practices. So here's our care provider at the bedside with a non-invasive blood pressure cuff. Nice piece of technology we've deployed for healthcare. And here's what they're going to do with it. Right, I saw lots of cows upstairs on the wards here at Foothills. And what the nurse is going to do is he or she's going to get the information from that machine and either write it on a piece of paper in their pocket, and 4 hours later, they're going to go to that cow and they're going to enter the information. That's computerization of an existing process that doesn't work terribly well, right? You got lots of technology there, but it's not really getting you where you want to go. So, at Ottawa, we're going to a process-focused architecture. Moving to a process-focused organization at the highest level inside the hospital. The entire hospital is moving to a process-focused, a rigorous, disciplined, methodological focus on healthcare processes. What does that mean? We will not undertake an electronic clinical documentation project. I'm saying this here because I'm safe saying it. If I go back to Ottawa and say it, there are certain people there who will lynch me. But we're not going to do electronic clinical documentation. I put the graphic of the ornithopter in here because I'm trying to remind you that mankind learned to fly when we stopped imitating the birds. That didn't work. Let's go a different direction here. Let's not imitate paper in and of itself. What we're going to do is we're going to redesign care processes, and in so doing, redesign clinical documentation to deliver benefits in quality and productivity. So we're not just taking paper processes and turning them into electronic processes. We're redoing the process itself, and as a result, the paper documentation or electronic documentation will fall out of the new process design. And I'll show you what I mean by that. So the Ottawa Hospital uses clinical technology to enable better healthcare processes. We'll automate, standardize, and optimize all repetitive, low value add clinical tasks, all order entry, order distribution, order execution tasks, all high value clinical care documentation. Right? And what this means is we're not really going to use technology to enable better care. That's not really the case. The Ottawa Hospital is going to use technology to drive healthcare processes. We're going to use technology to drive the processes themselves. If you want to have quality and cost control, you're going to use technology to drive those processes properly. So, what does that mean in practical terms? In order to support automated clinical workflow, most clinicians will require mobile devices, right? So you already heard this. The Ottawa Hospital has deployed over 3,000 iPads to clinicians for order entry and results review, and we're using them to engage clinicians in processes. We became the first hospital in the world to place an electronic order using a native iPad app back in March of last year, and we're rolling out electronic ordering with the advantage of our mobile devices right now. We're now moving our electronic whiteboards onto the mobile platform, right? We have electronic whiteboards in the walls and nursing units, moving it out of the mobile platform. Why? Electronic whiteboards allow you to communicate not orders, not results, tasks. You're able to engage the clinicians in tasks. Each patient is a row on that whiteboard, and little icons over on the one side represent the tasks that individual is associated to do. So mobile technology allows you to communicate with your providers, allows them to see what tasks there are, and allows us to instrument the care tasks. So what we're really doing here is we're moving to a world of business process management. This is our current state, and this is the current state here at Foothills, I expect. You have a bunch of care providers up there, and they're interacting with systems in a kind of a random, provider-driven, non-standardized way. And you get the outcomes you'd expect, non-standardized outcomes, right? Non-measured processes, because you know what the hell people are doing. This is where we're going, right? Provider's still there, but there's a process model that they are following and participating in as part of the process of care. And that process model is designed by them, not designed by me, designed by the frontline staff. Say, okay, how do you want to do this? Okay, that's how you do it. Okay, here's the process model. This is the way you flow, way you do this. Right? And the system helps identify tasks and post them to people by following the process model itself. This is how the rest of the world does what it does. Right? When you buy stuff from Apple, when you go to order packages from UPS, this is what they are actually doing. Right? No healthcare organization does this, but that's how everyone else does their business. At the Ottawa Hospital, nobody likes the word business process management. That's a no-no. We call it care process management, right? We trademark that name. This is what we believe it is. We're going to manage care processes. The methodology is like this, and I won't go through the diagram in detail. We don't have time, but basically, as I said earlier, we engage the frontline team as what is the process. And when I did this on our discharge readiness planning, which I'm not going to be able to talk about today, I ordered that there would be no administrators in the room at all. I said, we'll not let the leadership administrative leadership into the room in any way. Frontline people are going to design this totally. The administrative leadership said to me, they're outside the door. I said, well, we want this. We want like the stage change of it. And I go, guys, stay away. This belongs to the frontline team. If you come in and order them what to do, we're going to get nowhere. They have to own it in the end. They're never going to buy it if they don't. Right? They have to own it. So it's not a top-down order everybody do stuff thing. It is a get people to do stuff, but get them to design the workflow. Now, once they designed it, then variations of the workflow are their problem. Right? You agreed this was the workflow, guys. You said, why is that not working for you? Okay, if it's a big issue, we'll go back and rebuild it. We'll modify it. This is a cyclic process, right? But if it's just Joe doesn't want to do it, then the care team has to engage because they agreed to the process. The technology helps you operationalize this. I'm not going to go through this slide. It's very busy. But this is the architecture we need to do this, right? The blue is the application layer, and you have an application layer here. The light blue above it is the communication layer that connects all your applications together, and I suspect you have some of that stuff here. The sort of rose-colored stuff is the care process technology layer we've inserted into this. And the top part is the mobility layer, which I've already talked about, right? And then you see the providers using mobile devices. The leadership of the hospital says, are you getting iPhones for the nurses? The answer is yes. How else do you intend to do this? Right? You're going to have no choice, right? Suck it up, get ready. Like, get ready. And why are we going to do it? Because the process engagement orchestration is going to become so important to us, the cost of the iPhones is going to be nothing. So what does all that mean? Where is the Ottawa Hospital going? Back to the bedside. And I'll show you some examples. Electronic ordering, the electronic ordering process for diagnostic imaging. This process is live, right? This process is live is what we're doing right now. So the physician writes the electronic order. They could do it on a PC. They could do it on an iPad. The order is routed to two places. It's routed to the radiology department. Our radiologists get an inbox of all these orders. They review them to prioritize them and determine what protocol they're going to use to execute that exam. At the same time, it's flagged on electronic whiteboards on the units, so the nursing staff can see there's a new order. The radiology department schedules it. The nursing staff review the order, so they've seen it, they know what's happening. They can write it on a piece of paper if they want to, it doesn't matter to me. And then once we have a scheduled time, we communicate that time back to the unit to tell them we have a time for that exam. We can then bring the patient down to the exam at the correct time. We can prepare the patient and so on. And we capture the image, et cetera, et cetera. We scan the image, make it available on the iPads, get speech recognition. You know, this is a cartoon, right? But you can see the role of the process orchestration in what's happening. Most people look at electronic ordering, want to focus on that box up in the upper corner there. But the actual process is like that. This process that we're running is electronic end-to-end. The entire process electronic. That's what you do with process-focused architecture. Here's our lab testing. Same basic thing. Physician writes the electronic order. We flag the order to the whiteboard. The nurses review the order. We flag the scheduled time for that order. Right? When is it supposed to happen? We can flag that. The nurse then goes to the patient's bedside, scans the patient's barcode with a handheld device, prints the labels, labels the blood at the bedside, and sends it down to lab with a machine-readable label. This process is paperless end-to-end. Once again, it doesn't mean you can't write it down, but the process does not require any paper. It's auditable, measurable, engageable, implementable. You want to get somewhere in terms of delivering quality service, this is the kind of thing you're going to do. Okay? Electronic MedRec. I don't know what you're familiar with electronic medication reconciliation. It's a huge issue at the Ottawa Hospital. Medication reconciliation, for those who may or may not be aware, is the comparison of a patient's pre-hospital visit medications with the medications we're giving them in hospital. So we transition patients to the outpatient world into the hospital, check to make sure that we haven't missed anything. Then when you discharge them, you reverse the process. You take a look at what you are giving them and you transition them out of the hospital and make sure that all the medications they need have been prescribed when they leave. We're doing it on paper now. Compliance is limited. It's not bad, 70% compliance, right? We've got a pilot live of electronic MedRec. It's worth a talk all its own, but it basically looks like this. The system identifies the med history tasks. when the patient's in the emerge, patient's in pre-admit, or the patient admitted to the hospital, right? You can identify this task, and we tell the pharmacy techs that you have to take the patient's med history online. We have flags to identify that. We have lists of patients that need the med history done, and we can therefore guide the pharmacy techs to the correct patients that need the med history done formally on the computer. Once they're done, we can now flag the physicians to do the med rec for admissions, transfers, and discharge. We have flags on the screen that identify this. And the physician reconciles the meds online. And then we have a reminder flag, orders have to be printed. As you can tell, we don't have this interface to our pharmacy computer yet. That's a work in progress. So what's the result of this? Remember, the docs hate it. We have 100% compliance with this pilot in our process, with this process in our pilot. We have 100% compliance with this. If you want to get MedRec done, if you believe it's a patient safety initiative, and we're getting 70% compliance on paper, doing this got us 100%, right? That doesn't mean there weren't change management issues, docs yelling, people visiting Dr. Kitts saying, what are you doing to me? Like all kinds of change management behind this to make it work. So I'm not minimizing that. But if you want to have quality care, the paper process did not achieve this. Wasn't auditable, wasn't manageable, who did, who didn't, you couldn't deal with it, right? I told them when this is in pilot, right? We're going to go live between now and Labor Day, the whole hospital. I told them, when we go live for the rest of the hospital, that doesn't mean everyone will do it. I will be able to tell you who's not doing it. You can have a phone call with them, and you can deal with it. That's what you're going to get. But if you believe the process is better quality, the manual efforts we've made today are insufficient. Electronic allergy documentation, we're in meetings. This is not live. Those three things I just talked about are live. This one's not live. And my team said to me, we're doing a design electronic allergy or entry screen. And they said, you're not going to make the docs do it, are you? I said, damn well I am. What are you talking about? Of course the docs are going to do it. Well, no, we can't do that. They'll kill us. I go, really? Okay, guys. So let's be practical here. So we're going to flag who needs to have their allergies done. Same thing as I just talked about, right? We're going to let the med students document allergies. We'll let the nurses document allergies in certain areas of the hospital. We'll let the pharmacists document allergies. That's fine. I don't mind. But what the technology is going to allow us to do is say, okay, who is finally accountable for those allergies before he or she writes the med orders? Not the med student, not the nurse, not the pharmacist. And in the end, it's me. Right? It has to be. I'm going to take this to the medical advisory committee of the hospital. If they disagree with this, that's fine. We'll change it. But I don't think they're going to be able to, because they know, as I do, the physicians are responsible to review allergies prior to writing med orders. That's not happening today on paper. You may think it is, but it ain't. So this is where it takes you, right? In addition, we're going to do messaging and so on, because we can start messaging people, right? Once you've got mobile technology, you can start bugging people. Now, you can't go overboard with that, because you could easily design a process that would really get me lynched. So we don't want to go that far. But you can use instrumentation to focus in on these people need to be messaged to do something. So you can do even more than the whiteboard. You can actually go as far as messaging, because we've got the mobility infrastructure in place. Electronic vitals. You schedule the vitals. You identify the vitals are supposed to be done. You can have the nurse or other member of the clinical team go do them. You can message them they're supposed to do them. Right? Our whiteboards electronically link the care team members with the patients. You know who's supposed to do the vitals. You know who's supposed to do allergies. You know which resident's looking after the patient. You can therefore link, you can be more specific. You don't just broadcast messages to everybody. You identify the specific people that are supposed to get the message. So we're going to capture the vitals online. Take the device that measures the vitals, connect it to the network, and transfer the vitals directly into the network. Right? Nurse is not going to be taking that piece of paper and looking for a cow to go write down the vitals. Right? Transmit the vitals directly into the network. You can then do alerting. You can do warnings. You can do all kinds of stuff and communicate that, back to the providers. Right? Something you can't do on paper. Managing fall risk. This is, once again, something we haven't done. Screen people to identify who's at risk. Identify that some people need a full assessment of whether they're at risk for falls. Communicate that need to the care team member who's supposed to do that. Based on the outcome of their assessment, you can identify that these people need monitoring for fall risk. Right? You don't want to monitor everybody. You want to monitor some people. Okay, so now what are we going to do? We know the computer knows Mrs. Smith needs to be monitored. What's the computer going to do? The computer's going to talk to Mr. Smith in this case, Mr. Smith's bed, and say, are the rails up? Is Mr. Smith in the bed? Right? The beds do this, guys. They're computers. This is what they're very good at. Right? You can now alarm. Now, instead of having alarms go off all over the ward, you get an alarm go off for the 2, 3, 4, 5 patients who actually are at risk. The rest of them, they can get out of bed if they want to. But these people we want to watch carefully. Does that seem like a manageable process? Doing fall monitoring on every single person, probably not practical. Identifying these people that you want to monitor, that you can do. And then you can message. You can say, this is the nurse on call. Remember, our whiteboard tells us which nurses look after the patient. We can message directly to that person. I have a bed exit alarm on Mrs. Smith. Right now. Go to that room right now. She is out of bed. Right? Take it a little further. Right? Technology driving the healthcare process. I'll blow this out quickly because I'm taking too much time here. This is our medication process, once again, proposed, not implemented. Same basic idea, right? Last step I've skipped over there is we're going to use our technology to program the pumps from the pharmacy computer. The pharmacy computer has the order in it, transfer the order to the pump so that the order is correct. Eliminate the manual steps and deliver quality. Okay, let's get back to saving Lewis. Let's talk about what won't work. Policies. Ottawa Hospital has thousands of policies. Real businesses do not have thousands of policies. Some people may need to cover yours. Policies are stupid instruments of process. They're stupid. When you get to the allergies discussion, when they're telling me, so we're not going to make the docs do it, I said, what does the policy say? It says the docs do it. So don't we do that? No. What do you mean? Where don't we do it? And they listed all the places where the docs don't do it. I said, but we got a policy that says they do. They're stupid. Posters. That's my favorite, posters. Let's put a poster up. Like, no offense, guys. It's not that posters are bad. But a big sign saying, always wash your hands. Really? Really? That's what you think is going to make people wash their hands? In services. That's everybody's favorite. Just a month ago, I ran into the head of the blood bank. She'd just been to do an in-service. The nurses had transfused a bag of blood into the wrong patient. Now, some of you clinicians appreciate that is a catastrophic, absolutely must never, ever happen event. If you transfuse the wrong blood into someone and they have preformed antibody to that blood, the blood will be destroyed in the bloodstream in a matter of minutes, triggering an inflammatory reaction inside the patient's own bloodstream. A catastrophic event is never, ever supposed to happen. And what was our approach? Went and reminded the nurses to be extra careful. Really? You think that's going to work? Right? Fortunately, blood types matched. Well, got away with that. In-service done, we're off to the next challenge. Okay, really? Not quality. New forms. Ottawa Hospital has thousands of forms. Care providers always dream up forms to ensure care quality. Not going to work. And shouting, right? Let's do some more shouting, right? None of this is going to work. It isn't working now. That's what you're using today. It's not working. Safety by design. In engineering, we're not very trusting. We don't believe that God reminds us that when things are going to go wrong. He doesn't. Good stuff doesn't happen by accident. You have to design things. This quote is from Sons of Martha, which is a poem we all know, which reminds you to design things properly. Don't wish for good things to happen. You have to design them intentionally. And I hope I've shown you from these process models that what we're going to do is instrument process to deliver specific values. Right? Values in quality, values in safety, values in cost. So what might have worked? Automation and monitoring. If you look at the transcripts of what happened to Lewis, you can reconstruct this data, right? This is vital signs the last 24 hours of his life. They ignored these numbers. Now, we can talk about the cognitive biases they used to ignore them. We can talk about all the mistakes they made. You can yell at them. You can say they were bad people. But the truth of the matter is, if they had seen a display that looked like this the last morning of his life, they would have saved him. You don't need really complex stuff to do this, right? It's pretty obvious. They had those numbers. His pain score was off the scale, right? His blood pressure was falling. His vital signs had been abnormal for hours and hours and hours. All you had to do was take a look. Take it further. Okay, let's just suppose we don't believe that's enough. Computer can look at that. Computer can read that. You could monitor that. You could identify, we will do this, right? You can flag the criticals. You could have messaged people. So even if the display wasn't enough, you could add in more layers of safety if you believed it was important. Right? It's really not that hard. It does require discipline and execution to get here. And that's where most institutions are not focusing on the value proposition or trying to get other technology investments to arrive at that place. Okay? I hope I haven't said anything too controversial, and I hope I haven't made you hate me, but that's what I think. That's where we're going, right? And I apologize if I run over time.